Thank you. I have two, so hopefully I'll avoid echoing. We're good? Okay. All right, thank you for having me. Thank you to the organizers, Drs. Lee and Hanauer. I operate in a bit of a unique space at Northwestern. I do several different things, but my main niche is small bowel and nutrition. And we've heard a lot about evidence or lack thereof in certain cases. I operate in this world where there's really no evidence. The largest clinical trial of impact has 80-some patients in it. So my one disclosure, and I have this slide, but my one true disclosure is a lot of what I'm going to tell you today is not based on these large prospective double-blind placebo-controlled trials. It's more expert opinion, it's more based on cohort studies, and it's more about individualized therapy for your patients rather than trying to put your patient into a study. So that's the main disclosure. The other disclosure that I have is all of the stuff we've heard this morning talking about how to get your patients with IBD better or prevent bad outcomes. This is one of these bad outcomes that we've all been talking about trying to prevent but haven't exactly gone and said it. These are your patients who, if they fail therapy multiple times and have surgeries, these are the types of patients that we're going to talk about now. And ultimately, all of our drug therapies are designed in one way or another in patients who have Crohn's disease to prevent this outcome, in addition to others, but this particular outcome as well, of having short bowel syndrome or intestinal failure. And we'll talk about what that means. So we'll talk about what intestinal failure is, which is the overall umbrella, and short bowel syndrome specifically, and then the treatment options. So intestinal failure is the inability to maintain nutrition by mouth or in some cases by tube. And that can be from a variety of different reasons. Short bowel syndrome is under the umbrella of intestinal failure, meaning that you can't maintain your nutrition based on oral intake or enteral intake alone because you've had surgery to shorten your bowel. So short bowel syndrome is intestinal failure based on loss of bowel. People sometimes define this as less than 200 centimeters of small intestine, less than 100 centimeters of small intestine, things like that. I tend not to use those definitions, although sometimes they're practical when you talk to payers. In reality, the length of bowel that's remaining in continuity with your stomach is less important than what location of bowel is still left. And this is my homemade drawing that I spent a lot of time making, I must admit, and it didn't turn out very well, but a drawing nonetheless that goes over real estate of the small intestine. The real estate towards the stomach, your duodenum and proximal jejunum, is responsible for absorbing heavy metals, irons and things like that. As you move into the jejunum and towards the ileum, that's where your water-soluble vitamins are going to be absorbed. Some of your proteins are going to be starting to get absorbed, and your sugars. As you move distally into your ileum, now that's when you're going to get your fat-soluble vitamins, and then in the terminal ileum, B12. And a lot of this makes sense clinically with our patients with IBD. If you have terminal ileitis, then you're going to lose B12 and things like that. So when you start losing bowel, where you lose bowel is important. And where you lose bowel, I'll go back to the previous slide, is also important depending on whether you have your ileocecal valve and your colon attached to your small bowel. A patient who has their ileocecal valve and colon, but a very, very small segment of small bowel, is different than a patient who has a longer segment of small bowel to an end ileostomy. The patients with their colon are going to be able to absorb water and other things more so than patients who don't have a colon. So it's important to know not only the location of the small bowel that's been lost, but also whether or not the colon is there, as well as the ileocecal valve. So when we talk about management of short bowel syndrome or intestinal failure in general, the goals are to maintain hydration. And first and foremost, hydration is the most important thing. What gets patients into trouble is not, oh, I'm losing weight because I'm not getting enough protein and calories. It's, I'm in dehydration, my kidneys are failing, my electrolytes are really low. That's what's ultimately going to bring patients into the hospital and have increased mortality, or morbidity and also mortality. So the goal is to maintain hydration first and foremost. We also want to get patients protein and calories, micronutrients, and ultimately maintain and then gain weight. Patients, on the other hand, may have that flipped. They're going to want to gain weight. If they've lost a lot of bowel, their BMI is low, they're going to look at weight as the ultimate outcome. You have to really counsel your patients that that's a good outcome to have, but that's more of a long-term outcome. Now, the strategies to get those goals, to maintain hydration, get protein, calories, micronutrients, and things like that, are going to depend on what's lost and what's left. I'm going to pause here, and before we get into strategies, the one thing that I'm going to focus on is short bowel syndrome in a patient who has no inflammation. A patient with inflammation is a completely different patient, and the management strategies are totally different. To manage short bowel syndrome in a patient who has active intestinal inflammation, it's nearly impossible. It's very, very difficult. In order to manage a patient with short bowel syndrome adequately, you need to get the inflammation under control. If the inflammation isn't under control, you're not going to be able to manage any of these goals. So what I'm going to speak to is a patient who does not have any inflammation. If the patient does have inflammation, get that under control first and foremost. While maintaining the goals, you're probably going to have to give them hydration and things like that, but really focus more on getting that inflammation under control. So depending on the degree of malabsorption will depend on what you do pharmacologically, as well as diet intake. As malabsorption moves along, as the degree of malabsorption worsens, you're going to focus more going from diet to medications and then ultimately parenteral nutritional support. So fluid management, a patient who has problems with hydration, the goal is to maintain their hydration orally or through a tube. And the best way to do that is to have your patients drink. And the types of fluids that you want your patients to drink are fluids that are going to be absorbed the best. In order to absorb fluid the most efficiently, you need salt and you need sugar around. You can't just have free water. The concept of oral rehydration solutions are rooted in this, and that's based on the cellular data of the channel SGLT1. And in activating SGLT1, having equal salt and sugar, you're going to start absorbing water more efficiently. And that's where oral rehydration solutions come into play. And the best oral rehydration solution is the World Health Organization oral rehydration solution, and that's on the right. You want something that's isoosmolar, and that is about 245. You want something with equal parts sodium and glucose. Not too much sodium, not too much glucose, otherwise you're going to get your osmotic load up and you're going to draw water into the lumen as opposed to absorbing it out. The problem is oral rehydration solutions don't taste very good. Admittedly, I've tried most of them all, and most of them don't taste great, which is where patients then say, well, you know, I don't like your oral rehydration solution. I get that I need salt and sugar around. I get that that's how I'm going to absorb fluid the best, but it doesn't taste good, so I'm going to drink some sports drink. Problem is, sports drinks will not give you any information regarding their osmolarity or osmolality. They won't give you information regarding the sodium or glucose primarily. They'll give it to you in grams and whatnot, but they won't give it to you in millimoles per liter. I've tried calling all the companies, and none of the companies will tell me this data. Ultimately, different labs have gone and tested it, and none of them are very good. I will say that now. They have too much sugar, not enough salt, and you end up either losing water or having more of an osmotic output. So telling your patients to drink a sports drink isn't the same as telling them to drink oral rehydration solution. It's a good thing, fluid is good, but it's not necessarily optimal. Water, of course, doesn't have anything in it. Water is good, but it's not optimally absorbed. So what I tell my patients is drink at least 64 ounces of fluid a day, if not more. I want some of that to be oral rehydration solution, and there's different oral rehydration solutions out there. And try to avoid sports drinks if you can. If you like it, fine. But really, water and oral rehydration is what you should be advising. Whether patients listen to you, that's a completely different story. You want to avoid caffeine, and you want to avoid high sugary drinks, and you definitely want to avoid things that have artificial sweeteners in them that's going to increase the osmotic load going through the intestine and then draw water out rather than absorb water in. So fluid management is important. If you can't maintain fluid by mouth or by tube, that's when you go to your intravenous solutions. And that's what ultimately we would like to avoid. If you need to, you need to. Going from fluid to diet, again, avoid the high osmotic additives. These are your artificial sweeteners. Tell your patients not to chew gum that's artificially flavored. We have patients who sit there chewing on gum all day and they wonder why they're getting dehydrated. They wonder why their oral rehydration solution isn't working. You tell them not to chew gum, and they're better. It's amazing how impactful these artificial sweeteners are, these high osmotic additives can be. Going back to the original question, small frequent meals will optimize gastric emptying. Chew well, eat slowly, and then ultimately eat food first. Allow your stomach to break the food down and then drink sometime afterwards. If you eat and drink at the same time, it's going to increase gastric emptying. The goal is to have the stomach eject stomach contents, eject food into the small bowel at a more linear rate rather than exponential. And that allows your small intestine to then process the nutrition and the fluid that comes through in a more efficient manner involving surface time. You want to maximize the amount of surface time in the shortened bowel as much as possible. This is where your drugs come in. You want to use drugs that maximize your small intestine. Drugs not only that decrease the amount of fluid that the body produces going into the small intestine, both gastric and duodenal fluid, also mainly to prolong transit time. The first question in here was about the most medical student question I've seen so far, but it's a question nonetheless about transit time. You want to slow transit time as much as possible. You want to prolong this transit time. You want to decrease noxious diarrhea. So you don't want your patients to be having a lot of stool output, and we'll define what noxious diarrhea is. And then ultimately, if all of these things don't work, you need to produce more small bowel. You need to increase your absorptive surface capacity. So we'll talk about all these in detail right now. Number one, this goes along with hydration management. You want to decrease fluid secretion. You don't want your body producing fluid that you're going to end up losing. We know that patients who are post-op produce high levels of gastrin, which then drives gastric acid secretion, which then drives increased gastric fluid and drives increased duodenal fluid. Patients post-op can produce up to 4 liters of fluid a day. That's a ton of fluid that you're going to end up having to reabsorb and replace. So I put a lot of my patients on acid-blocking medications who have short bowel syndrome. Proton pump inhibitors are the best. If you need to, H2 therapy is fine as well. Octreotide or somatostatin analog can do the same thing, although it's much, much more expensive. It's inconvenient. Patients have to inject themselves or take depot. It can increase blood glucose, and it can also produce gallstones. So use it carefully, but it is a good therapy, not only to help decrease fluid secretion, but also decrease and prolong transit time. So that is another option. Prolonging transit time, your go-to standard therapies are your loperamide and diphenoxylate. This is coming from the article that's listed below. It's from JPEN. It has a lot of this information. Again, these are relative guidelines from the nutritional societies based on very little clinical data, more on expert opinion, so take all of this with that in mind, but recommendations nonetheless, and these are the doses that I use these drugs. Remind your patients to take these bowel-slowing agents before meals, ideally 30 to 60 minutes before, so you get the levels higher in the blood, you decrease small bowel transit time, and then you feed the small bowel. It's important not to chase food with these drugs because they're not going to make much difference. I tell them to take it before meals and then at bedtime, so overnight you're losing less fluid. Loperamide, diphenoxylate, you can also use codeine, and don't forget about tincture of opium. It's very, very effective. It's been around for a while. It doesn't taste the greatest, but it works well, and I don't see many patients who are referred to me on this, and I think it's a good drug. Noxious diarrhea, so what's going to increase fluid secretions? What's going to cause your patients to have higher ostomy output or diarrhea? These are your standard type diarrheas that you see in general GI. Bile salt diarrhea, steatorrhea, bacterial overgrowth, problems with diet, taking in these osmotic additives. Don't forget about these types of things. Don't overlook somebody who might be having steatorrhea, and you can put them on pancreatic enzymes and they feel better. Or if they don't have a gallbladder, or they're not recycling their bile efficiently, if they don't have their ileum, don't forget about bile salt diarrhea. Oftentimes adding a bile salt blocker, adding pancreatic enzymes can make a world of difference. So I often have to remind myself that in addition to treating patients' nutrition, I'm also a gastroenterologist, and I have to think about GI type things, right? So don't forget about your general GI in this regard. Parenteral support. So when all this fails, and you're left with a patient who you can't get under control using diet, you can't get under control using medications, you can't get under control with fluids, then you have to go with parenteral support. Whether you give them in total parenteral support with nutrition, electrolytes, and fluids, or you give them part of this. Some patients it's necessary, especially if they're inflamed, if they have problems with magnesium loss because of inflammation, if they have problems with protein loss because of inflammation, things like that. Now, when you have a patient on parenteral nutritional support or parenteral hydration support, there is an out, and this out is called teduglutide. Teduglutide is a synthetic glucagon-like peptide 2. GLP-2 is a natural occurring peptide that is released by L cells. L cells are located in your distal ileum proximal colon, and they feed back on the small bowel, causing growth and proliferation. It's not the only thing that causes growth and proliferation, but it is a main component. What do you lose when you have surgery for Crohn's disease? You lose your bowel around the ileocecal valve. You lose these L cells. You don't have the natural occurring hormone that's going to feed back and cause growth and proliferation of the small bowel. You're going to lose villus height, and you're not going to have the surface area that you normally would. So teduglutide is a synthetic glucagon-like peptide 2 that you can then give back, which causes an increase in villus height and causes an increase of enterocytes, and can help you with absorption. It can help get patients off of parenteral nutrition support. Alternatively, there are surgical options. This is more popular, at least used to be, in the pediatric world. You have a number of different options that either lengthen the small bowel or increase surface area. You also have the option, hopefully, if you're lucky, of restoring bowel continuity by reattaching the bowel to the bowel that's been excluded for whatever particular reason, creating the J pouch or internalizing a diverting loop ostomy. Don't forget about that as well. So these bowel lengthening procedures are not common, but internalizing an ostomy, if possible, is something that you should consider if that's a possibility. That can really give you an increased amount of absorptive capacity. How do we monitor these patients? Briefly, we look at a number of different things, including urine output. We want patients' urine output who have short bowel syndrome to be over 1 liter a day. That's ensuring that they're getting enough hydration. We want their electrolytes to be balanced, including magnesium and phos. If you start your patients out on aggressive therapy, who have been losing weight, who have been malnourished for a long time, watch for refeeding. It might be reasonable to put your patients in the hospital for a couple days so you can monitor for this. You want to watch your micronutrients and essential fatty acids. Depending on what real estate they've lost will depend on what you watch out for. I typically draw micronutrients every 2 to 3 months until I know they're stable, sometimes sooner. And essential fatty acids I'll draw once or twice a year just to make sure that I'm on the right track and they're getting the fats that they need. Protein balance, you can check nitrogen balance if you need to. Oftentimes, the surgeons come to me in these types of patients, and before they operate, they say, well, you know, is the patient's nutrition good enough for surgery? And they point to their albumin or they point to their prealbumin and it's low, and I might not be able to get those numbers up. Well, if a patient's in a positive nitrogen balance, meaning they're making protein rather than losing it, then I tell them, yeah, their nutrition balance probably is pretty good. And then don't forget about frailty. If your patient is frail, if they're not getting out of the house, if they're not getting out of bed, if they can't climb upstairs, but yet they have a normal BMI, they seem to be well hydrated, nutrition might be playing a role, especially in patients who you may not think about the short bowel syndrome. They may have had a resection or two, but they don't meet criteria in your mind. If they're frail, don't forget about nutrition. And that's it. Happy to take any questions.